Urinary tract obstruction. Etiopathogenesis. The obstruction of the urine flow impairs the renal and the urinary conduct function due to the associated stasis and the elevated of the urinary tract pressure. The urinary tract obstruction is the common cause of the AKI and CKD obstructive nephropathy. Congenital causes like the abnormal insertion of the ureter into the bladder, most common cause. Vesico-ureteral reflux and the posterior urethral valves, most common cause of the bilateral hydronephrosis in boys. For the acquired causes, the nephrolithiasis, most common cause of the urethral obstruction in the younger men. Benign prostatic hyperplasia, most common cause of the U2O in men. Malignancies, cervical and the bladder cancer, they are the first and the second most common cause of the malignant ureteral obstruction, respectively. Abdominal aortic aneurysm, most common vascular cause of the UTO. Prognosis, recovery of the renal function depends largely on whether irreversible damage has occurred. The course will depend on whether the obstruction is complete or the incomplete, bilateral or unilateral, if infection is present. 1 to 2 weeks of the complete obstruction may still have the partial return of the GFR. After the 8 weeks of obstruction, recovery is unlikely. For the clinical manifestation, most commonly presents with the pain, capsule distension, polyuria and nocturia, commonly accompany for the partial UTO. Hypertension, this is frequent in the acute and the subacute unilateral UTO or in the CKD from the bilateral UTO. Evidence of the distension of the kidney or the bladder by the palpation and the percussion of the abdomen. Genital and the rectal examination should be done to check for the prostate, pelvic or the rectal masses. Duration. Acute. This is usually due to the intraluminal obstruction such as calculi. Severe renal calci with flank pain and the hematuria and the nausea. For the chronic, usually due to the ureter strictures, malignancy, iatrogenic causes. Dilation. Unilateral dilation of the ureter, hydroureter and the renal pyelocalcisis system, hydronephrosis. This occurs if the obstruction is above level of the bladder. For the bilateral, this occurs if the lesion is at or below the level of bladder. For the location, extrinsic and the intrinsic. For the extrinsic, from the compressive or the restrictive force. For intrinsic, from the intraluminal obstruction such as calculi tumors or the palpilla. Diagnostic test, chemistry, acidemia plus or minus uremia. This occurs when the overall excretory function is impaired. Bladder outlet obstruction, bilateral obstruction or the unilateral obstruction in the solitary kidney. In some, distal RDA, hyperkalemia and the renal salt wasting may occur. Urinalysis, hematuria, pyuria, bacteriuria, normal urine sediments. For the abdominal ultrasound to evaluate for the hydronephrosis, renal or the bladder, size of the pyelocalcia counter or the possible causes of the obstruction, radioplaque stones and masses. Non-contest high resolution CT scan, advantages in visualizing the retroperitoneum and identifying the intrinsic and the extrinsic sites of the obstruction. Safe for patients with the renal impairment. Retrograde or the anterograde urography for the visualization of the suspected lesion in the ureter or the renal pelvis without the risk of the contrast nephropathy. Widening cystourethropy for the vesico-urethral reflux and the bladder neck and the urethral obstruction. Management. Initial intervention. Insertion of the bladder catheter is both diagnostic and the therapeutic analgesics. If complicated by infection, need for the immediate relief to prevent the development of sepsis and the progressive renal damage with the urologic intervention. For example, nephrostomy, ureterostomy or the urethral or the suprapubic catheterization may need the prolonged antibiotics. Chronic or the recurrent infection is a poorly functioning and obstructed kidney may necessitate the nephrectomy. If without infection, this may delay the surgery until the acid base or the fluid and the electrolyte status is restored. Post-obstructive diuresis, polyuria may be massive after the relief of bilateral complete obstruction, where the urine is hypotonic with a large amount of the NaCl, potassium, magnesium and the phosphate. If stable replacement with the IV fluid in the amounts has been urinary losses. If with the hypernatremia due to the loss of electrolyte free water, give the half saline IV fluid while monitoring the serum and the urine sodium.